edition of DE's Recall Visit, where we take a deeper dive into some of our favorite recent articles from dental economics. And so from the June issue, which will be hitting your desk any day now, if it hasn't already, we have a focus on endodontics. And with us is one of my good friends, Dr. Diwakar Kinra, who is an endodontist in Flint, Michigan. What's up, man? How you doing?
Hey, thanks for having me on. I really appreciate it.
Oh, it's my pleasure. So you've written for us before. You've written a great article here about, it's titled Lessons in Endodontics, Advantages of Adopting New Imaging Technologies, which is a really interesting premise, of course, because endodontics is one of the few procedures we do blind. And it doesn't totally have to be that way. We are able to see more to help us treat more and diagnose more. And so your article gives a really nice overview of some of those things. You talked about magnification and illumination. I'd love to jump in, though, to the imaging. So you use digital radiography in your practice, of course, as a modern endodontist. And I think a lot of GPs, we learn to take so many radiographs, master cones and working lengths and all of these things. And perhaps some GPs start to fall off that academic preparation and take fewer images. So I'd love to hear from an endodontist perspective, from your perspective, what images are you taking? What are the critical ones that maybe some of the GPs are missing? What do you think?
When I started my practice as an endodontist in 2004, we started digital right off the bat. And so it was kind of a natural segue for me to, try to get the type of images I wanted when the patient walked in. So I wanted to get a straight on view of the tooth. So I take one PA right when they walk in. And then I also take an angled PA because I can see with two images a greater amount of information than I would have with one. And because of the, the speed of the image that you get now with the digital radiograph, I will always take a check film during the procedure. And usually that check film is done like a master cone film, what you would usually take. I do now probably skip that step of working length because I have so much trust in my apex locator that I feel pretty comfortable with that and trusting that versus taking a radiograph at that point. And then at the end, I take my final obturation picture without the rubber down, and so that I can send that back to the GP who sends it to me. So, in that, there's not a lot of room to skip other than just the radiograph that you would take for working length film. Is that something that you would, usually do when you're at your office? What radiographs are you taking comparatively?
Yeah, that's interesting. I've been trained to take the master cone before we filled, and maybe that's because I'm not doing endo as routinely as you are. And I trust my apex locator, but I still sometimes, maybe I've learned, the fill ended up being a little bit shorter or a little bit longer than I thought it would be. And so I've learned to try to do the master cone. But it can be a cumbersome step when you're still trying to isolate this area and if you put your cones in. So that's very interesting to just maybe build some skill set with your apex locator and making sure you're accurately measuring where those rubber stops are so you can have that confidence. Is that's kind of what you're thinking?
Yeah, where I see people making maybe some mistakes is that when are they taking their working length film? Usually when I'm doing my shaping, I do a little bit of coronal third shaping. Some people do it with the gates glidden. I do it with an orifice opener. And you realize that when you do that, you're kind of straightening the top third of the canal out. And that actually shortens your working length. So if you take a working length right at the beginning of the procedure and kind of not do anything till later on, you'll see that you might be about 0.5 millimeter to 3/4 millimeter long. So that's where some of those working length errors occur. So if you can kind of control that after you do like maybe the first coronal third shaping, you're going to find that you're going to be much more accurate with your apex locator. And
that's fantastic advice. Thank you. So I wanted to ask you one more question about using CBCT, which you also go into in your article. And there's some controversies, of course, with the public and amongst some dentists that maybe this technology gets used too much. I certainly don't fall into that camp, but I'm sure you just like with any kind of radiology, you like to be conservative when you can be. So tell me, when is it that you as an endodontist are using 3D imaging, CBCT, in your diagnosis or throughout your process? When do you say, okay, it's time to use that?
That's a great question. I'm a new user to CBCT because in the state of Michigan, it's just been, the certificate of need has been lifted. So a lot of us are getting more comfortable with it, using it. We use it in our office every single day. So when I look for information that I want, I go to the AAE and the joint statement that they came out with, the oral maxillofacial radiologist, and they came out with some ideas of when you should use it. And so, you know, I first started off just using it when I was going to do a retreat or a surgery. That was the first idea. But then when you really start to go into it, I felt like, man, I really could use this more and more. And so I'm using it in complicated anatomy. I'm using it in resorption cases. I'm using it more often than you think I would, than just, you know, what I would think of in the beginning of my procedure, such as, you know, I thought maybe retreat surgery. Now I'm looking at it, complicated molar cases, premolar cases, even mandibular anterior cases where there might be two canals. It really gives you a lot of information, and it's like the virtual microscope for me. That's the way I look at it.
Right. You know, I heard of that. Michigan had a very unique rule in place that was preventing dentists from using this technology, or made it more cumbersome. So I'm happy to hear that got lifted. I mean, would you say this is something that you're using now every day? As an endodontist, obviously you're doing endo all day long. Is it an everyday usage for you?
I have to say that in the beginning, it wasn't an everyday use. But I think that was because of my discomfort level of acquiring the image and being able to read what was on the film in front of me. And so now that I'm more comfortable with that, I feel more confident in using it every day, because the amount of information I get, I think the benefits outweigh the risk to the patient. And I have all my patients that I actually show them the cone beam that I'm looking at, and they're really amazed at the technology that we can provide in the dental office. They want that.
That's a really interesting point. And again, getting great technology doesn't all of a sudden make you an even better dentist. It's becoming comfortable with it, but also maybe taking continuing education or you know, getting whatever resources are available to you to make sure you're actually accurately using the technology. So in your case, being able to read those films and identify, just like it takes us a long time to identify and use radiographs correctly, you spend some time getting more comfortable with that. That's a great point. So speaking of continuing education, when can people see the good Dr. Kinra in a live event coming up, or any other places where you're speaking coming up?
In September, I'm speaking at a couple different places. So at Dentsply Sirona World, we're going to be talking about a couple cool endodontic projects that we're working on. We're going to be talking about single visit root canal therapy. We're going to talk about case selection. And also, I'm coming up with a new lecture about common pitfalls that you would come about in your everyday practice and how to overcome those common pitfalls when doing endodontic procedures. And then at the end of September, I'm going to be in Dallas doing a 3DU, which is put on by Cabo Kerr, which is kind of a all things cone beam. I got to tell you, that's a really cool symposium. I think that everybody's doing that. That'll be a lot of fun.
Fantastic. That's great. Well, I have seen you lecture. It was one of the best endodontic lectures I've ever seen, and I mean that. I'm not just saying that. So anyone would be wise to take one of your upcoming courses. Thank you very much for joining me today, and we'll talk to you soon.
Hey, I appreciate you having me on. I'll see you soon, buddy. Thanks.
Take care.